All right, welcome to the hospital to hospital ambulance transport webinar. The goal of this webinar is to get you through some basic information on hospital to hospital transports. I'm Tom Ryan with Provider Outreach and Education, and I'll be your presenter today. Today, I'm joined by Aline Ziegler, who's going to work with the chat, offer a little bit of technical support. I did ask one of my clinical staff, Mary Sue Gardner, to sit on, as there are some questions that came in that if I do need clinical help, I want to be able to answer right away. I'm not a clinical person. I don't have a nursing degree or anything like that. Mary Sue does, so that's why we're going to use her in that manner if we need to. So if you have a question, throw it in chat. Remember, only put it in chat once. One of the first things I wanted to make you aware of before I even leave this slide, we did have some questions come in that are regarding the portal and the usage of the portal. And some of that was documentation questions and information regarding that. So I did want to let you know that we are currently in the process of making updates to our portal, which is the secure section of our website. You may have heard this coming out for a long time. We talked about phase 2 of the website being updated. I don't have an exact date, but I want to remind you that that is happening. So what we do have currently is available on YouTube to help you through those sections, and it includes things like uploading documentation. So that's there for you. However, do expect that that information will change. A couple of you asked what information is changing and what do we know is changing. One, we're going to try to keep the functionality the same because that's what you asked for. But two, we want to make some enhancements to the underlying stuff, so the programming and the servers. Our goal is to make it more stable and to work faster. Hopefully that's going to help you guys in the long run. So I wanted to let you know that that is coming. Hopefully that answers any of those questions that have submitted on that. Also, we don't have an exact release date. That's still more to come. We're waiting on the programmers to give us that. We only get to see it after they give us all that information. Let's move on from there and let's do a bit of a disclaimer. So again, we prepared this education as a tool to assist our provider community. It is not the official rules, laws, or regulations. Those are on the Center for Medicare and Medicaid website. They're in the Code of Federal Regulations and they're in the Social Security Act. I may mention each one of those items throughout the presentation, but the day-to-day operating instructions are on the Center for Medicare and Medicaid website. If you're using our website, you are getting guidance from your contractor, not necessarily the official operating instructions. One of the things that came in was some of the questions that came in, I'm only going to be able to answer based on the questions and the facts that were given in the question. So I'll give you the best answer that I have, but keep in mind Medicare rules determine final coverage and those rules can change. What's nice is hospital to hospital transport hasn't changed in quite a while, but it is still being looked at by a variety of different medical review contractors. So please be aware of that. Another item I want you to be aware of is CMS does prohibit the recording of this presentation for profit-making purposes. That means no screen prints, that means no actual recording, anything like that. Instead, what we're going to do, record it, we will post it. We will post this directly on our YouTube channel as an encore. Take a look at it in that manner if you need it. Also, download the material. It is available on our live events page. Once we put that onto the encore section of YouTube, it will be available for 60 to 90 days. It just fluctuates a little bit there on the encore page. If you need CEUs and you want to listen to it as an encore, that's the opportunity to submit that material. We don't actually give that. A little bit more will come about CEUs and information you'll need a little bit later on. So what are we going to cover today? We're going to cover medical need, hospital to hospital transports. When is it medically necessary? We're going to cover some documentation tips, and I'm actually going to show you some information for documentation. And then we're going to talk a little bit about some inpatient information and what you need to understand about inpatient, because there's some key things you need to know. Our goal is to help you understand when Medicare will cover a hospital to hospital transport. Though it's very similar to a lot of other things, there are questions that arose. So those questions are what we're trying to answer and trying to help you get through. So our goal is to get you to have that understanding. That's why I asked that you put questions in the chat. But remember, once you put it in the chat, give us the opportunity to hit the questions section and actually be able to answer those. Don't submit the same question multiple times. That takes time to sort through and to try to get everything answered, and then actually takes away from your opportunity to ask questions. All right, so again, what's the first section? Well, medical need. Anyone who has dealt with Medicare has probably heard me and Mary Sue, Aline, we've all said the same thing. So let's talk about what is medically needed or what shows medical need. First of all, keep in mind this is from the Social Security Act, and we'll talk more about that. So again, our goal is to explain what are you looking for, what is Medicare looking for with medical need. Keep in mind your training, the training you receive to get medical skills may be different when they say medical need. Also, state laws do not override federal laws. And we'll talk more about those different things during this medical needs section. So the very first thing you need to do when you establish whether or not a hospital-to-hospital transport is something that Medicare will cover is you need to establish that it is medically necessary. You may hear in different aspects of transports or different aspects of the Medicare program that if it's not medically necessary, you need to do this, or if it's not that. Keep in mind, for the ambulance benefit, there is a section of the Social Security Act which spells out that it has to be the only safe means. The actual word they use is on this slide, and you can see it's contraindicated right here in the middle. This means that if this service is not medically necessary, it is the patient's responsibility because it is not a Medicare benefit. You cannot bill it back to the hospital, leaving or destination hospital. None of that. Once we do that, we then have to look at, okay, yep, it's the only safe means of transport, but then what else makes it a payable transport? First, is it a covered destination? So is it a hospital or a recognized facility like that? Now, in this case, we're specifically talking about hospital to hospital. So Medicare is looking to make sure that the destination is a hospital to hospital transport. There are such things as off-campus hospitals. Some of you may be familiar with that. Some of you may not be familiar. We're going to talk about that in a little while, but it is still part of a hospital. One of the big ones that has started to come up with that are those freestanding ERs. If they're hospital owned and operated, they are normally considered off campus. All of their participation, all of that is based on what the hospital does. Now, keep in mind, a state licensed hospital does not mean that it has to participate in Medicare. There are such things as what is commonly referred to as a Medicaid hospital. These are still state licensed hospitals, they just don't participate. So Medicare does not state that the hospital has to participate in Medicare. Instead, it states that it needs to be the origin of hospital for the ambulance transport to be recognized. The last bullet point on here is to give you that Social Security Act and to give you a link directly to it. You can check this out at any given time. And it also then goes through the sections and subsections. So you want to make sure that you're aware of this when you talk about it, because without this, you don't have a payable service. So what establishes this safe means and information? And that's what we're going to talk about next. So we know that we have to establish somehow that the only safe means of transport is ambulance. So what makes it contraindicated, or what establishes that? Active treatment. This is something done by an EMT, emergency medical technician. Now keep in mind, in some states, some regulations state that a paramedic is separate from an emergency medical technician. When we talk about the federal regulations and the way that CMS has them written, they define an EMT in 3 categories: basic, intermediate, and paramedic. So when we look at that, you will be assigned into one of those 3 categories. So when I use EMT, unless I'm specifying an EMTP for paramedic, an EMTB for basic, or an EMTI for intermediate, I'm using the general term EMT. It means covering all of them. So what are we looking at when we look at active treatment? 1, they have to keep the patient stable. I'm going to talk more about that. 2, there is something life-threatening without the EMT, or there are drugs that are needed. Okay. So when we look at that, we want to look at what is the training, what is the medical training that is going to be used by that EMT during the transport. If there's medical skills or medical training, that's what we're looking for. Now keep in mind, this is definitely not an all-inclusive list. There's a lot of other things that go into it. One of the questions we did receive, again, is can you define the being stable, the patient being stable? Now I did ask Mary Sue, and she may have some more information in just a moment to weigh in on this, but the term stable is very hard to define. There is no definitive meaning. And each type of practitioner, whether that's a doctor, whether that is a nurse practitioner, whether that's a PA, they use the term stable differently based on their training. So here is where we have to sometimes seek clarification from the facility. Show up, you go to do your assessment, and the nurse says, hey, the patient's stable. Well, what does stable mean to you today in that facility? Also say, hey, we documented their blood pressure's this is this, this is this. This is what we're going to use as the term stable, or this is what we're documenting. Those are the signs, symptoms, whatever the EMT should also be assessing. So stable alone will never be enough, to support the need for a transport. Even if you get something from the doctor saying the patient's stable, what does the doctor mean by that? Are they using the evaluation and management definition of stable, which means they've reached a certain goal, and once they reach that goal, they're stable? Are they using an EKG to show, so is it over a period of time and they've taken 15 minutes and they've had a consistent heart rate? Or maybe not. Maybe the monitor shows the exact opposite. So we need to know what stable means. Did you have anything to add to that?
Hi, Tom. Yeah, just the one thing I encourage all of our providers to do or to consider is, think of the word stable as being a subjective term. Anytime you can give us objective information, a length, a weight, a percentage, an amount, a frequency, it is only going to behoove you in your documentation. So even saying that the vital signs are within normal limits is acceptable as more objective than subjective, because there are standard numbers for medical vital signs, that makes them within normal limits. So again, try to avoid those subjective terms, because it's kind of like, is doing better. Nobody really knows what better is. Better than what? Better than me, better than you. So yeah, include any kind of objective and measurable terms that you can. Thanks, Tom.
Thanks, Stu. So hopefully that helps everybody kind of understand, and I did hopefully get a good answer to that question. If not, I would like you to put that back in chat. We can talk more about that in a little while. Next question that came in was monitoring, and basic question was first, does Medicare cover monitoring? And the answer is absolutely. There is no reason that Medicare can't cover monitoring, but we still have to look at whether or not monitoring is needed. And this is where some of the documentation is not supporting that particular item. So first, Medicare wants you to look at why the EMT, what skills, why the EMT needs to monitor that patient. Please don't use terms like patient is bedridden or patient is on oxygen. This does not support monitoring. Why? Well, bedridden does not mean they cannot get up with assistance. They cannot be moved into a wheelchair and ride in a wheelchair van. It's a very general term. Again, you heard Mary Sue use the term objective and subjective. Same thing goes here. Also, patients receiving oxygen. There are a lot of patients that walk around with oxygen every day. So just because they're receiving oxygen doesn't mean that it's medically necessary. One other question came in, well, patient doesn't have oxygen supply available today, but they need it. So we have to take them this way because they don't have an oxygen supply available. Okay, but what are you monitoring? If the patient did have an oxygen supply, would you be needed to monitor that oxygen? If you answer no, then that's not a medically necessary transport. Just because they don't have a tube of oxygen doesn't make it medically necessary today. So when we look at that, we do have to look at a variety of different things. Also during monitoring, you have to explain why the patient could not go in a different means. This could be medical restraint. This could be physical restraint. What are you doing to make sure this patient is in that particular method? Now, again, were there drugs administered? When you show up at the hospital, did the nurse tell you we administered these drugs, therefore you need to do the following? Well, you may not actively be working with that patient at that moment, but you still need to monitor that because of the medications and the other things that have been administered. That all needs to be explained. So with this, someone asked, hey, for monitoring, can we use a report given to us by a nurse from a hospital? Sure. so long as it's given to you in advance. If you don't know the information, it doesn't support the medical need. Why did you assess them? What did you look at them for? What medical training were you using? What does this have to do with it? So if you say, hey, I gave you an admission report from the second hospital to support the need for the ambulance transport, we're not going to use that. And why? Because that admission report wasn't known before you transported them. The EMT can't act on that admission report at the time. They could, on the other hand, act on the original one given to them. So that's why with monitoring, we don't automatically give any assumptions, first of all. Second, we do look at what is explained and why is it there? What are you doing? So please understand, monitoring gets to be a bit of a different situation, but I do want you to understand that Medicare does pay for it. It's not that we do not pay for it, okay? Please be careful with general or generic terms. General or generic terms will not work. We have to have some measurement. Why are you monitoring? What's making the EMT's need available? Again, so if you have more questions on monitoring, let's put that in chat. We'll talk about those in a little while when we get to questions. Another common scenario that we were asked a lot of questions on in the past is hospital to hospital for mental health transports. Very similar to monitoring. We need to know what is going on with this patient at this moment. Why do you need to transport them in this method when the EMT showed up to transport them? Okay. Now, do you need a physician certification statement for this? No, it's going to either be a one-time transport or it's going to be a non-scheduled transport, which is under 24 hours. So you don't need it. Is it helpful? Yes. Mental health, it's always helpful. Tell us why the patient feels this person may be in potential harm of themselves or others, why they needed the medication, or why are they even sedated in the way that they are? What's going on with this patient? Key things to keep in mind. Potential harm is great, but saying potential harm, here's the history, and there's no actual showing of any information about why the patient's not, or is the potential to harm themselves today? Okay, so I'm glad you have a history, but what's going on today that shows that? Now, if you said, yeah, we showed up and the patient, every time they're transported, does this, and so therefore they were medicated this way, which means we need to monitor them because, okay, so there's a difference there. We added a lot more detail and we helped understand and build a picture. Especially with medications or drugs or whatever you're getting, we want to know what's going on with that patient. But you still do have to prove medical necessity. I understand you pick them up and you're taking them from an ER or from a hospital and you're going to move them to a psychiatric hospital for care. Medicare does not automatically pay that. There's no automatic payment in the Medicare program for that. You want to still have the EMT do the assessment. During the assessment, explain what's going on, what did they find out from personnel, all of that different pieces of information. So with that, I did put this slide together just to give you a little bit of what is really needed and to get a bit more information. So if you're just using the terms that are listed on this, we need to understand a lot more. First, bedridden. I explained this one already. Bedridden in and of itself does not make it medically necessary. Why are they bedridden? Why can't they stand? Why can't they stand with assistance? Do they need one or more? Can they do a pivot? Can they sit in a wheelchair? What's going on with that patient other than just bedridden? Oxygen dependent, very general term, not giving us any need for you. Many people are oxygen dependent if they have their own canister. Some of them have their little oxygen machines they carry. We need more than just oxygen dependent. Isolation is another one. It kind of goes with contagious. These two kind of go together. First, isolation alone is not a reason. So what does that mean? What is isolation? Why are they needing to be isolated? What is the doctor trying to get from? What are we trying to do? What are we trying to keep them from? Sometimes they've already been exposed or they came in with a family member. So that's a person they're already exposed to. So now do we want to add an EMT, someone else to move them into that riskier situation? I'm not saying yes or no, and I'm not saying we don't pay for isolation. We do. Medicare considers it, but Medicare has to look at the safest method for that patient. Would it have been safer for something else? Now, the same thing happens with contagious. We had a lot of these come in where a person came in and they weren't showing signs or symptoms for certain things, but they're contagious. They've been there so many days at the beginning. Okay, well, somebody brought them in and that person's already been exposed. So when they're contagious, why are we putting them into an ambulance transport if that's the only reason? If the person who was already exposed, so why are we not utilizing that person to transport them? First, they're contagious, I understand that, but they're asymptomatic. Okay, well, what makes that contagiousness something that's so severe that they can't go by any other means? They can't be loaded back into the car that they came in with the person that they came who's already been exposed versus putting them into another situation or exposing more people to whatever it happens to be. So again, I want you to understand none of these, am I saying Medicare doesn't pay for it? What I'm saying is help create the picture, help us understand a little bit more. Also, there was a question that came in and it talked about Medicare's denying their return trip to a facility. So it's a hospital, but they're going back to the original hospital. Okay, so that's very interesting. In a hospital to hospital transport situation, if you leave the ER and go to another hospital, whether it's for testing or not, we're looking at, does that potential hospital have the need to treat you? If they do, what's the medical need to go back to the first one? So we are going to deny that because it is two separate trips. Keep in mind, I said it's outpatient related. If you happen to be inpatient, then it becomes part of the hospital bill. So we still have to look at medical necessity. There's a variety of other factors, but it becomes part of the hospital bill. That's where round trip is the only time it's used, is when a patient is actually inpatient, not under observation, but inpatient and admitted in that manner in a hospital. So hopefully that answers the question. If not, please let's come back to it. And you can go ahead and put that in the chat. Which brings us to the first round of questions. So the first one that I have, and then we'll go live, is what does Medicare cover round trips to and from a facility? When does Medicare cover it? Again, I just explained this. Be very careful. Medicare doesn't technically cover a round trip unless it's part of a facility. The facility itself, once they are inpatient, cannot bill an ambulance transport on their claim. That round trip becomes whatever they're being done. So if you're sending them for an MRI and that's where the facility is at, but they have to go back because they don't have a bed other than to complete the MRI, you're not discharging them from your facility. You're just giving them the MRI. The ambulance transports gets billed to where they're inpatient at. And then that MRI is also going to contain the expenses for the transport. It's not a separately billable code. So there's been a bit of confusion on that in hospital to hospital transports. So that's the first question that we do have. And I want to check with Aline to see if we have any more.
We did get one question early on, and it goes right along with what you're talking about. And Rosanna says, we are a hospital that can provide services not available or not able to be performed at other hospitals. For example, the patient is at a critical access hospital in the emergency department, where they give an example, an ERCP cannot be provided, so they are transported to our hospital. The patient requires other services and cannot be safely discharged. We had a room available for the procedure to perform the ERCP, but we don't have a bed available for admission. Would the returned ambulance transport back to the critical access hospital be covered by Medicare?
Actually, in that case, and I want to make this very clear, if that was documented properly, it would be covered. Because what needs to be documented is that, yes, you can do the test, right? But at this point, you can't take that patient. So you got to send them somewhere else, wherever that is, whether that's the critical access hospital or a different hospital, whatever. You do not have the bed available. So the test is one thing. And yes, the ambulance transport to you for the test would be covered. And then the back would be covered, but it's covered because you don't have a bed available. Remember, key definition, bed, staff, and equipment. So for hospital to hospital, we have to look at all three components. So hopefully that answers your question. If not, throw some more information into the chat for us. Aline, any other questions?
Yes, we do have another question from Donnie. Is there any documented CMS accepted definition of what deems a patient's status to be critical, and critical is in quotes, with regards to elevated level of services provided for hospital to hospital transports?
No, there's no that I know of, there is no technical definition for the word critical. And again, some of that comes into play with the way in which the term critical is used and what that actually means to each individual provider. So the term critical in and of itself, as far as my understanding is, and I'm going to ask Mary Sue to weigh in, hopefully if she's listening here, but it's not necessarily always going to mean the same thing to the same provider, and that's why CMS doesn't have that. Now, keep in mind, they do say that there are certain things, if you're talking about critical for specialty care transport, that it needs to be a certain level, or an EMT needs to have to perform it by state licensure. So there's a variety of different factors that go into critical. I want to ask Mary Sue if she has anything else she'd like to offer on that.
I don't, Tom. I think you covered everything. Thanks.
Okay, so again, be very careful with the term critical. Explain to us what is critical about the patient. Why are you using that term? Who's assigning the term? It's just a very hard term to define for Medicare. All right, not hearing, Aline, you said that was our last question. Is it still our last question?
We did get one more, just real quick here. It's from Sharon. Can you talk about hospital to hospital within the same license? Is there a mileage between hospitals rule?
Interfacility off-site facility, I think, is what you're talking about here, and I do have some information on that later in the presentation. But basically, hospital to hospital, and when we're talking about the same license, it's an off-campus. That's how CMS defines it. Now, keep in mind, when I say CMS, it's actually coming from the Code of Federal Regulations, and it comes from the hospital information. So the Code of Federal Regulations does define for us what off-campus is, and they actually do have a portion within that that says 250 yards. I know that I can, later on in the information, I'm going to give you a Code of Federal Regulations or CFR reference for that. But again, it's 250 yards. Once it becomes beyond 250 yards, even if it is the same hospital, even if it's the same licensure, even if it's the same tax ID, yes, Medicare will start to consider some different things there. So again, we're going to have to look for medical necessity and why are you transporting them? This comes into play with freestanding emergency rooms, for instance, or where there's a hospital off-campus department and then another department that works with this, or maybe cardiology is in one building and ERs in another building. Lots of factors into that. So I will hopefully be able to get you a better reference for that. I know that I do have one. It's just later on in the presentation. Any other questions?
No other questions at this time.
Perfect. Next, I'd like to talk about documentation because this is where on hospital to hospital transports, when the medical review contractors, and it's not just us, I want to make that clear. Yes, we're reviewing this in some areas, but there are also other medical review contractors that are coming out and saying, hey, your documentation is an issue. And you being the ambulance providers, that's what they're talking about. So we want to give you the basics of documentation and get you through the information for some of those different key elements that you need. So of course, before we get too far into documentation, we always have to start with the basics. We do have a documentation article out there. I want to show you where it's located because it's got a lot of great information. So let's get started with showing you where it's located. Then we're going to go through the slide. So step one, of course, you're going to go to our website. This is the WPSGHA.com website. Remember, I talked about the fact that we're under a redesign. So when you say MED, it's just a redirect. It's a temporary thing for that purposes. You can search ambulance right up here in the top, but I want to show you where this is located. If I go ambulance, or if I go topic center and claims, now I know there's a documentation section. When we redesigned it, it has not been moved yet, so you need to go to claims. I like specialty and service, but you can use whatever you want. When I go into ambulance, there's 3 articles. An ambulance documentation article is not here today. Let's see if it got moved. Now, keep in mind, I did request that it was removed. I looked a little bit earlier today and they are making changes. So let's take a look at documentation and see if it got moved over here. And it did. So instead of topic center, I want you to go to documentation. And then here's the ambulance documentation requirements. Again, as I said, it got moved this morning after I checked. So what's great about this article, and again, there's a lot of information in there. It's going to give you the basics of documentation, which we'll go through, and then it's going to talk about all of the different things you need to know and make sure are documented. This article was written with support of our medical review department to make sure you're meeting the documentation requirements. They had some issues coming up, so they wanted myself and Mary Sue to work on this to make sure you have everything you need. So I wanted to support, point this out again. Going to go topic center, documentation. Once you're in the documentation, I happen to like specialty in this. I think it's the easiest way to find it, and then you can open up the ambulance documentation. If you don't want to do that and you just want to download the presentation and select the link right here in the bottom, absolutely you can do that. This will open it up automatically without having to go anywhere. Makes it super easy for you. It does look a little bit different. Again, this morning I did remove all these jump links that were within it, and now it's just the straight documentation article. So let's start with some basics. This sounds very generic, but the first thing we look for is, even before we look for medical necessity, before we look for a treatment log, before we look for anything, is there a transport date and time? If there's not, we have nothing to review. Even though you build it in a certain manner, if I don't have that within the documentation, there's nothing to review. The origin and destination addresses. This is actually one of the most common missed items, and it's not just that there's a name. I need to know the origin and destination addresses. Origin, a little more flexible with the zip code. Destination, not so much flexible. You want to make sure you have the full zip code, which is 9 digits. So you want to make sure your origin and destination are there. I need mileage. Key thing with mileage, we will assume that this is loaded mileage or per patient mileage or any of that if you don't have any other indication there. That's fine, but also when we look at mileage, if you have, this is my indicator of when I started from the garage, then we went to the hospital, we picked them up, we drove to another hospital, we dropped them off, and then we went back to the garage. So therefore, this is my total mileage per trip, and you bill us total mileage. This will cause a downgrade or an error. And yes, on hospital to hospital, this does happen. Okay. Then we look for the patient identification information. What's their name? What's their date of birth? All of those basic pieces. We want to make sure that information matches as closely to Medicare as possible. Now, there are some common things that people do accept. For instance, Tom versus Thomas. We can make certain pieces of the information work. But if the date of birth is off, if something else is off, we may not be able to accept that documentation. We also need to know who treated the patient. Now it says treating EMT. This is where you need to put BIP or whatever your state associates to that. So are they a basic, intermediate, or are they a paramedic? What level are they at? So not only do I need a name, I need some credentialing with that. Signatures, I need the treating, and I need the patient signature. Without those two items, we're automatically out. Now, if the treating is not the assessing, so if someone else did an assessment and you are using that assessment, I need a third signature on who did the assessment. Whatever you do, you need to make sure every single item is signed, okay? Then we're going to hit that treatment log, and this is just the information about the transport. A lot of people will call this your run sheet. That's fine. Call it whatever you want, whatever you feel like it needs to be heard. But without those basic pieces, we will automatically stop and not even consider medical necessity. We will not even go any further. And every single one of these will be consigned as a contractual obligation. So when we deny it as part of our responsibility because you did not provide the information needed to make a medical determination. These are not going to be something that will ever go to patient's information or patient responsibility, with the exception of sometimes the patient information, if you don't have the right Medicare number, will go there because we'll be like, this isn't an eligible patient. So with that said, they're not eligible for Medicare, not a Medicare beneficiary. That one may go, but the rest of these will all be provider responsibility. Let's move through a little bit more information. When we look at the EMT assessment, this is such a key piece of information. I've mentioned this again and again and again. So what we're looking for is, what did you hear? What did you feel? what they saw, what they smelled, and any history they know. Someone once asked me, well, what do you mean by smelled? Alcohol would be an example. Did you smell alcohol? Did you smell zoners, such as other drugs, things like that? Did you smell pot? What did you smell? When you looked at the person, were they out of it? Were they not able to function? Were their eyes rolled up? Pupils blown? Anything like that? Same thing with heard. What did you hear? Did you hear them rasping for breath, unable to catch their breath, unable to, or instead of labored breathing, really shallow breathing? So is it super labored, really hard, really shallow? What did you hear? For dislocations and other things like that, we do want to know what you felt. What did you actually feel when you touched the person? What's going on? Was there extreme swelling? Could you see that it was very red, so you touched it and you felt the heat radiating from their skin? All of that type of thing. Last one, history, is kind of a more general or all-encompassing terminology when you look at this. History encompasses what someone else also told you. So what do you know about this patient? Maybe this patient's a flyer and you're like, yep, every Tuesday they call us and we're good. Okay, here's what we know about that. Or maybe the history incorporates what happened at the original hospital, at the ER when you went to pick them up. That's going to be history. That's part of what the reason for the transport is. Maybe the history is the daughter or the son or another relative, another family member, another side person is there that might be just a neighbor. What did they tell you? What are they helping you understand? That's still all history during that assessment part, because what you're looking at is how to determine how you're going to treat that patient, right? Part of history would be, is there a physician certification statement, or is the physician telling you something? Is the nurse telling you something? And did you document all of that? So that big category is history there. I want to make sure that we're aware that that's what the assessment is, because that's where you're going to come up with a bit more information. All right. Next, we do want to talk about this in particular, and this is air-to-air transports. So when we look at air transports from hospital to hospital, remember there's some different components that go into this. One, if it's rotary wing, this can be directly from hospital pad to hospital pad, helicopter, right? If it's fixed wing, it's actually always going to be 3 transports. 1, hospital to site of transfer. 2, site of transfer to site of transfer. And 3, site of transfer to hospital. So when we talk about hospital to hospital, each leg must show medical necessity. So how that's all done is up to you guys, but you do have to document the same basic pieces of information. A couple of things to remember. Time to destination becomes key here. Would we have been able to get that patient there via the ground in a timelier manner? Okay, so what that means is it's going to take me an hour to get this ambulance, fixed air ambulance to that particular airport. Once we get them there, now I still have to transport the patient to the air ambulance. Now they have to taxi, runway, et cetera, and then them back. So total transport time is going to be around 3 hours. But if I drove them, we could get them there in 90 minutes, which is safer for the patient. Now, I'm not saying that just because it's longer time, it's automatically safer for the patient to go by ground. That's not what I said. We will look at and evaluate that based on the patient's condition, the EMT assessment, and the information given, which could include the air assessment, but not at the initial time of transport, not on that first pickup, because they wouldn't have that information. So we really want to make sure we're aware of what is going on here with this. For documentation, one of the biggest questions I got was on physician certification statement. They did have a lot of back and forth this kind of questions. So I will tell you, I'm going to give you some base information. Then if you still have a question, let's get that put up into that chat so I can answer those for you. All right. So physician certification statement does not justify the need for transport. I've said this. It is the justification coming from the EMT assessment at that moment. The reason that it does not justify is because a physician can certify a transport for whatever they believe, whatever they want. Their training is different, but it is a way that it will support the need for the assessment. And if we're supporting the need for the assessment, then we're directly supporting the need or lack of need for the transport. It may help drive your EMT as to what they're looking at. So it's going to include why this professional, whoever that professional is, believes this is medically necessary. Hopefully they have that in there, and it's not just transport them. Well, in that case, it doesn't do anything. We actually got a physician certification statement in that I chose not to include, and the example said they need to go to a higher level of care facility. Okay, but why do they need to go? How is that useful? And the information was not there. That's what was verbatim on there. Well, okay, so the EMT now has to justify why you pick them up at this facility and why they need to go to this higher level of care. Well, in doing that, they actually got a report from the nurse that told them what was going on with the patient, and that was part of it. So better than the physician certification statement was the discharge report coming from the nurse that they got. That's why Medicare cannot just rely on a physician certification statement alone. Somebody asked me the question, so I put this on here, does it need to be called a physician certification statement? And the answer is no, it does not. Sometimes it'll be an order or a reason for transport, or it'll be a transport form. Medicare doesn't say it has to be called this name. The physician certification statement is just a general terminology used for you. I will tell you that we do offer a sample physician certification statement on our website. You're welcome to take a look at that. That physician certification statement is designed to encompass a lot more than just hospital to hospital transports though. So please be aware of that when you're looking at it. You're like, well, this doesn't make sense for hospital to hospital, or this doesn't make sense for hospital to hospital. I get it. It's just a lot bigger issue. And we'll have a lot more. I did ask Aline to put that in our chat for you. So if you were interested in that, you can take a look at that. All right. Advanced beneficiary notice of non-coverage. Many of you had questions on this. First of all, an ABN is very rarely needed, very rarely needed. The exception to that is when Medicare will, when the patient is transported by air, but ground would suffice. Their medical needs do not prove that air is necessary. That's really the one big time when it will be used. Other than that, for most situations, either it's medically necessary or it's not. If it's not, you don't need to give it. You don't need to give it. But keep in mind, if it is medically necessary and it is being downgraded, air to ground as an example, it does need to be complete and accurately filled out. If you're giving it as a nicety, you don't need to complete it. You don't need to do all of that. You do need to do the top all the way to the cost. You don't need to do the rest of it. It's, again, optional for not medically necessary. If it's an optional, it is not required to be signed, dated, anything like that. It's just a nicety. And some people say, hey, I did a hospital to hospital for a higher level of care. Do I need to give it then? And the answer is no, unless the doctor's ordering air, the patient wants to go by air, and you're saying, I don't know why this is necessary. Then you do need to give it to cover that air to ground differential. We do have a course on this on our website if you want to learn more. And it is in our YouTube area for the encore. So take a look at that if you're interested. All right, hospital reports. And you've heard me say this multiple times. So yes, they can definitely support the need for transport. But you have to know at the time of transport that the hospital report exists and what information you looked at. So if you just put a random hospital report in there and the EMT in their documentation never mentions that they used it for anything, that hospital report doesn't really help us a whole lot because we don't know what they did with it. Now, if the EMT said, hey, referencing the hospital report, this is what happened, and then the hospital report's attached, now we have a clearer picture of what they did with that hospital report. One of the things that can happen with a hospital report is it can give us a diagnosis. Remember, EMT is not able to diagnose, so we do need that coming from somewhere, and sometimes it's going to be the signs, symptoms, etc. But other times, if you have a hospital report, especially the discharge report from the ER, taking them to another hospital or for whatever reason, you're going to have a good diagnosis. One of the nice things about those hospital reports is it definitely helps to support what you assessed, what you looked at, what you did, all of those different pieces from the EMT. Question came in, and does a hospital report have to be in writing? And the answer is no, it can be verbal, right? You talk with the nurse and they said, do this, 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 and this. This is what we did. This is what we found. This is what's going on. Document that verbal communication. Why did you start with the nurse And obviously it's to get background, right? It's to get that history of what's going on to this patient today. And then why did you do the assessment that you did based on what the information that you got? Now, is it in writing? Is it wrong to get it in writing? Absolutely not. Absolutely not. But it can be verbal or it can be in writing. Also, I want to make it clear as possible, it is not required. The assessment is required to pay the transport. The hospital report is not required to pay the transport. Does, again, support the assessment, but not a required element. So let's talk a little bit about a couple questions that came in, and then we'll throw it back open for some more information. So question number one, we received an oral report. How do we document this? And I think I added this very clearly. An oral report does count as a hospital report. This is a report given by, could be a discharge staff, could be a registered nurse, could be anyone. And you're telling the EMT, this is what happened. This is the information you need. This is what you want to look at. This is why this is medically necessary. So it does count as a hospital report, though it's not in writing. It's just given orally. Also, we received a facility report after the transport, and Medicare is not considering this information for payment. So you received a destination hospital report, but Medicare isn't looking at it. Well, that's because you didn't know that information at the time of transport. How can your EMT actively assess based on this information and use this information to treat a patient if they don't know it? They can't do that. So it's very clear that we need information beforehand to be able to consider it. So when we come up with, and I'm going to ask Mary Sue if she wants to add in anything after this again. So when we come up and you hear the term hospital report, and then I say it can be an oral or it can be in written, is there a set definition that Medicare uses for a hospital report? The answer is no, there's no set definition. A hospital report could be a hospital record, could be a discharge summary, could be an oral report given by someone that works at a hospital. So Medicare doesn't necessarily define the term hospital report. Mary Sue, do you have more to add to that one for me?
I don't, Tom. I do encourage, though, that if you are taking an oral report, that you do document who you received that report from and what information they conveyed to you. So that it was oral report from nurse X at emergency room Z, and this is the info. Thanks, Tom.
Thanks, Mary Sue. And Aline, do we have any questions at this time?
All right, thank you. Kimberly asks for clarification. A hospital bed not available can be a valid reason for hospital-to-hospital transport as long as the EMT documents the patient could not be transported by other means?
That is correct. So one of the criteria for Medicare is bed, staff, equipment available. So if you don't have a bed, what are we going to do with that patient? You're going to hold them in the ER for 3 days until there's a bed available? When we can transport them 15 miles or 10 miles or 5 miles and say, yep, there's a bed available at this one. This is where they're going to go because they can get better treatment there. I can't tell you yes or no. In that case, that's up to the facilities to decide. Here's the thing. It does need to be documented. 1, there's no bed available. 2, why is the only safe means of transport the ambulance? If we can document both of those and then explain, yes, it could be potentially be covered by Medicare, again, depending on what's in the documentation. Next question.
The only other question that I see at this time is a follow-up on the PCS question. Can you say again where we can get that info on when a PCS is required?
Let's take a look at it. So if you look at it, if you look at the ambulance documentation requirement, I like to do this. If you're not familiar with Find, I just hit Control F. I put PCS right on in here, and it tells me information related to that. This policy is in, and it tells me where I'm looking at. Physician certification statement. Here's the elements that you need. I'm just going to keep going down for a couple of seconds here until I find the right one. Here it is. So if you go to our website, it's going to refer you to the Code of Federal Regulations, and here's the actual information, the link to the Code of Federal Regulations for you to find this information. So again, you're in the documentation on our website, search PCS. Yes, you do have to move down a few hits, but it'll bring it right out for you. So help. Go ahead and move on. If we have more questions, hopefully we'll get to them at the end. Let's talk about a few documentation examples. I just want to give you a couple of pieces of information. First of all, you will see the PEG marker on this one. So it was a 67-year-old male. He's vomiting blood. It was an advanced life support level 2 transport, so we didn't downgrade this. We said, yes, this was medically necessary. Total mileage was 46. It was a higher level of care transport. And here's exactly what was documented. Service not currently available. The facility or the ER did not have a bed available. We can't take this patient right now to treat this. So what we did is documented that. The example of the claim that had all the correct information, everything was there. So when they went through the targeted probe and educate review, there was nothing else to help us or nothing else that we needed. So what was actually contained within this particular example? The point of pickup. Now, again, you guys, I do have a destination and origin. They are redacted, right? Got little blue boxes because I can't give those to you directly. Destination, yes, it's there with an address. Do I have vehicle information? Do I have mileage? And so you can see vehicle was this, mileage is all there. Here's the mileage information. Do I have a date and time? Yep. Call time and date up here, transport time and date down here. So we have everything we need. A great breakdown here. And do we have a diagnosis? Now this came in on the claim, treat and transport. What they did with this particular one was here's the diagnosis as given. Here's the secondary diagnosis. This came from the impression that they went to the hospital to transport them, right? They have this information. What is the diagnosis? They have it because the hospital gave it to them. Perfect. Okay. Move on. Do they have a narrative? This is what's important, and this is what we're going to look at as the key. Okay. Today he received 4 pints of blood. Right here highlighted. We know that this patient is bleeding somewhere. What are we looking for? 4 pints of blood in addition to. Okay. Also, specialist not available, which makes this specialist a certain transport to a higher level of care. Now, higher level of care, not saying that if they didn't have a specialist there, right, they could. It just means today they don't have one available. And so that's also then highlighted right here in the documentation. So those were the key deciding factors according to our medical review department that we needed to be aware of. On that one, we did have a transfer form. It's an example of a PCS. Again, it is a transfer form. It gave them all of the information. What was awesome was, yes, this is signed by an RN. Yes, this is okay. Remember, I told you there's not as strict a requirement. It's the patient who knew the patient, who needed the information. That's great. Because this is a one-time non-scheduled, this would be okay to have signed by an RN. Again, we do have that. We know all the different information that we have and the key information, why they're looking to move this. Okay. So this one's a great example. I don't really have anything to say that would be better on this one. They did include some other pages for us: medical history, drug list, activity log, procedures, patient information, EMT information, and signatures. These were all, but again, I don't really have anything negative or a bad example of what to do with this one. So that one went under review. It got paid. We're good. Let's move on to example 2 for just a few moments. First thing I want to let you know with example 2, patient is 70 years old, shortness of breath due to chronic obstructive pulmonary disease. What's going on with this? We had a total mileage and a higher level of care, service not currently available. That's our scenario. What we wound up having happen is what was included. Well, we do have a patient's information. We do have an EMT assessment. We do have a narrative. We do have a diagnosis, point of pickup. Notice one thing that's missing right here. We have a hospital report from the point of pickup, but what's not on this list? How about the destination? Okay. Also, we have an EMT signature, but we don't have patient signatures. This claim never went through medical review because we denied due to missing information. This is the example that would be the provider responsibility. All right, let's talk about our third example. Same thing. This claim is not medically reviewed. It is denied because we have mileage, chain, and no bed available. That's literally what came in. It was a run sheet, and it had a little bit of piece of information. Here's how many mileage. The patient had chest pain, and the treating facility had no bed available. No assessment, no other information was given. So we're looking at all of this, and we're like, okay. Along with that, we didn't have a receiving facility, so we didn't go any further because we had him in a city, but nothing further. Nothing. Also, when you look at that handwritten information, it wasn't legible. Non-legible information cannot be given. With this, they did include a consent form. This consent form then said that if Medicare denies this, again, for not medically necessary, it's going to be the responsibility of the patient. This was not the case. We denied this for lack of documentation. Therefore, this consent form is not applicable, not a medical necessity denial. All right, brings us back to questions. I do know that we are running short on time. I will compile all remaining questions. If you do need to drop off, that's great. If you want to continue to listen, we will get through some more additional questions. So let's get through just a couple of questions, and then we'll compile the remaining questions as we go. First of all, Aline, was there any questions that were submitted?
Yes, we do have just two. We are a critical access hospital. Our ambulance regularly has to take patients back to the nursing home because there's no staff available to pick the patient up, or the wheelchair van is not available. Is this billable to the nursing home? And should we have a PCS for this instance?
So first of all, that would not be considered a hospital transport. Keep that in mind. A little bit outside of this. Second, I do want to answer that, and no, it's not billable to the nursing home. The ambulance transport is not medically necessary. Section 1861S7, I gave that to you way at the beginning, says it's got to be medically necessary. That's going to be patient responsibility. And that's just the way the law is written. It's not a Medicare covered benefit. Now, keep in mind, if you said to me, hey, by the way, I have this contract, and then when they don't have a wheelchair available, now I do for the nursing home, and therefore I have to bill them based on that contract, that's a separate legal document that could drive that factor. But in terms of Medicare, no, that's not a medically necessary transport, therefore it would be patient responsibility. Next question, please.
Yes, last question. If I'm understanding correctly, for an over and back or return ambulance transport to be covered, we need to have documentation to show why a transfer was not possible, such as lack of available staff, bed, or equipment.
Absolutely. So for hospital to hospital transports, we need to know why they went back. And it could be anything. I mean, it could be staff, equipment, bed availability. Just help us indicate why that's going on. You know, we understand that there are certain times your hospital is full, where the need is there. We just want to make sure that we have that documented somewhere within it. So we're not saying we don't. It's just back and forth. Okay. So I would like to thank you for listening. We do encourage you to provide feedback via this survey. Remember, we want to get the good, the bad, the ugly. We want to know how best to help you and get you what you need. Also in the survey, please include any other topics. They don't need to relate to ambulance. They don't need to relate to hospital to hospital. We just want to know in general what you're looking for. If you would like to sign up for some additional webinars, we do have some more coming up on ambulance. I do take the opportunity, I would encourage you to take the opportunity to check out our live events page to see what's coming forward. Don't forget to view our Encore playlist for the past information on webinars. We've done a variety of different pieces of information on ambulance. We want to make sure you're aware of that as well. On behalf of Provider Outreach and Education, Aline, Mary Sue, and myself, thank you for participating. We look forward to your survey comments, and we hope that you join future education. You may now disconnect.